presentation. Sorry, we had technical difficulties, but we are now going to continue on with our presentation. We're going to segue to non-invasive ventilation. So many people with ALS at some point in their course experience difficulties breathing. Now, surprisingly enough, for most of those people, the difficulties breathing start at night when they are asleep. There's several reasons why this happens. One is that most of us are laying down flat when we sleep. So instead of gravity helping our diaphragms to move, gravity is working against our diaphragms. The second thing that happens to all of us when we sleep, during REM sleep or dream sleep, we are paralyzed from the neck down, except for our diaphragms, and that's so that we don't act out our dreams. But for people who have weak muscles and weak diaphragms, that presents a problem. So for people with weak muscles, when they are in dream sleep, they aren't able to ventilate. They aren't able to get the good air in and the bad air out, and that leads to hypoventilation. Now, the symptoms of hypoventilation can be very subtle. So sometimes people have the very obvious symptom that they're short of breath when they lay down flat. But more often people will have just restless sleep. They kind of think they're asleep, but they're not sleeping as well as they used to, or they're getting up more frequently to go to the bathroom at night. Sometimes people with nocturnal hypoventilation will think that they're sleeping well at night, but during the day they feel very sleepy. They're falling asleep in front of the television, or they're taking naps, whereas they never used to need naps. For people with nocturnal hypoventilation, the treatment is non-invasive ventilation, otherwise known as BiPAP. This is delivered through a mask that's similar to a CPAP mask. Most people know what obstructive sleep apnea and CPAP is. Tight-fitting mask that goes either over your nose and mouth or just over your nose, straps up to the top of your head, and attaches to a machine at the bedside table. The mask for CPAP and BiPAP is identical. The machine is very different. The machine for non-invasive ventilation delivers a big breath and then releases to allow for exhalation. The Trilogy is probably the most common non-invasive ventilator that we use, at least in our clinic, and Kathy and Matt have a Trilogy here that they're going to demonstrate.
Okay, so this is what a standard setup for a Trilogy will look like in the home. And I will hand you, Kathy, this mask. And as you can see, attached to the stand here is also a humidifier to help keep the individual from getting overly dried out from the excess pressure. So what we're going to do now, you can see Kathy doesn't even need me here. She's an old pro at this, and she can do this herself. However, in the beginning, when you're getting familiar or acclimated to the mask, it can take some time, so don't get frustrated with that. And as you can see, it's very easy to breathe on. And this particular mask is what Kathy found works best for her. However, there are other options as well for people who may be claustrophobic. There are masks that just go over the nose, okay, as well as masks that are nasal prongs, or pillows is what they're called. So these just actually attach right up to the nostrils, but the whole idea is to try and help reduce any sort of feeling of claustrophobia, so we don't like anything really obstructing the vision. But that is your standard Trilogy setup that we use in home, and with that I'm going to pass it back to Dr. Diebold.
And in fact, we're going to, at this point, stop and take questions. So I'm going to ask the rest of the group to come back up here, and we'll take whatever questions the viewers have.
And while we're getting set up, I might just expand on some of the points that Nancy made, because I think they're pretty important. People often wonder why we're doing the pulmonary testing, and to just link some of the points that Dr. Diebold was making with some of the points that Nancy was making, we'll use a lot of these numbers in a lot of different ways, but commonly, for example, vital capacity and the maximal inspiratory pressure can be very helpful in helping us determine at what point a person might benefit from non-invasive ventilation, in addition to the symptoms that Dr. Diebold was speaking of. The peak cough flow, and I think to some extent maximal expiratory pressure, maybe you can tell me if you agree or not, are things that we'll use to try to get a sense as to whether somebody might benefit from a cough augmentation technique. So we use the different numbers in different ways. The breath stacking is something that some clinics use. We tend to use it a fair amount. Other clinics might use the cough assist initially or more commonly. There are lots of ways to augment cough. So,
Do we have the
So
questions up and running?
we do. Our first question was directed to you, Dr. Diebold. It is from a person with ALS who says that he gets very short of breath. He does wear a trilogy at night, and sometimes during the day he is walking, but feels he can only take about 20 steps, and he's so short of breath and almost feels like his heart is beating real fast.
Okay.
So he would like to know if he can improve.
What can he do to
Yes.
improve that? Of course, it's a tough question. So one thing to point out is that many people who have reached the stage of that degree of respiratory impairment can't walk any longer. So that in itself is a bit unusual, but not to say that that makes it not a problem. He should make sure that there's nothing intrinsically wrong with his heart or lungs. I'm guessing that that's probably the case, that his heart and lungs are fine, but especially if he were to have chest pain. I mean, could he have blockages in his arteries of his heart? That would be something that would be relatively very easy to treat and important to treat. If he had cough or sputum production, could there be something going on in his lungs? So those would be two things to consider. I guess the other thing to consider would be to have the trilogy on a stand and consider walking around with the non-invasive ventilator in place. I've had some people who have used that 24/7. I mean, there is no drawback to using that all the time except the possibility of irritation of the skin on the face from the mask. And some people will swap out like a nasal mask during the day and a full face mask at night, so there's different pressure points. So that would be one thing to consider, would be using the trilogy more.
Okay.
I might just add to that again. You know, we often think of difficulty with breathing as a late event or late stage event in ALS, but a small, but if it's happening to you, it's 100%. A small proportion of people with ALS have breathing difficulty relatively early as one of the sets of motor neurons that are affected early on. So we do see people like this who have good use of their arms and legs, but are having shortness of breath. And so it's a little bit of a reverse of what we sometimes have to deal with, so I'm really glad that you asked that question.
So the other question was for both Kate and Dr. Walk, submitted by email. They are asking, the individual has a feeding tube, cannot speak, but she tends to bite the inside of her lip, which causes her pain and annoyance. And is there something that you can recommend?
You want to start?
Sure. So that is a common question or concern that we get. And I believe when we talked before, mouth guards can be helpful, but really that is just unfortunately one of those things that we don't have a real clear answer for, unfortunately.
Yeah, I think it's a tough problem. Again, a bite guard will help, but obviously if this is happening when you're eating, you're not going to use that. I do refer people to their dentist to see if they have some other thoughts. I think, Kathy, you had said that you've experienced this as well.
One question is, when do I consider a feeding tube?
That's a really good question. That's a great question.
That is a good question that we deal with
Yeah.
every day in clinic.
Why don't I start with that? We often like to discuss this relatively early if we anticipate that somebody might need one at some point. The clear indications are either if we feel somebody cannot continue with safe swallowing, somebody's clearly losing weight related to feeding difficulties. Sometimes it's slow or very effortful eating. People have eating fatigue. It takes an hour to get through a meal, and it's not fun to have a meal anymore. So we'll raise that issue if we anticipate any of those things coming up. And we do try to be somewhat proactive about it because the risk of just going through a procedure becomes higher if somebody has developed a significant amount of difficulty with swallowing. With breathing. Those would be the major indications. Again, if there's clear development of unsafe swallowing, you can't easily manage, particularly if it's causing weight loss or eating fatigue, or if you anticipate that that's going to happen, and a person's reaching a point where their breathing is dropping such that we think, well, people sometimes say, well, I'm not ready for that yet. Let me wait 6 months from now, maybe I'll have the feeding tube. But 6 months from now, it might be less safe for them to actually go through the procedure because they're more frail, they've lost weight, or the breathing isn't very good. So we encourage people, if we see it coming, to be somewhat proactive about it. Do you have anything to add?
The thing I would add is just to really make it very clear that you can continue to eat with a feeding tube. That's something that I always try to make sure is understood, that you can get the feeding tube sometimes just for hydration, and then you're better hydrated, and then you feel better, so then you can even swallow better because you're now hydrated. Or get the nutrition and the hydration through the tube, and then you can eat just what you want, cake and ice cream, and get the nutrition through the tube. So I think that's an important thing to point out as well.
And I'm going to reiterate what Dr. Walk said about the respiratory issues. So in order to have the feeding tube placed, you have to be able to lay flat without any sort of mask for a period of time. And so I'll see people where that window of opportunity is starting to close, where it's just not safe to do the procedure. So you need to start thinking about it early and get it done early.
Yeah, there are actual guidelines, and what I say to people is at this number, you got a green light. At this number, in terms of your breathing, it's a yellow light. We can still do it, but there is some risk. At this number, in terms of your breathing, it's a red light. There's substantial risk of going ahead with the feeding tube, and you need to know that.
And I think that's something that's so great about an ALS clinic, is where we can all work together with our dietitian, who's not here today, to kind of work with us and you to decide when's best.
Yeah. Good question.
Question for you, Kate, from somebody who said that their individual with ALS can no longer use their hands and speak, and what are their options?
Well, so the eye gaze that I showed would definitely be an option, and so that, or the head mouse that was shown in the first part of this series, if you still have movement of your head, that you can use that to access a computer that then could help you communicate that way. I would talk to your speech pathologist, and he can work with you to find the best option. I hope that answered your question.
I think it did.
Okay.
There are no more questions that I see. Anybody have some final thoughts?
Thank you, Kathy.
Yes.
Very, very much.
Kathy.
And thank you, Cytokinetics and ALS Association. We hope this was
Yes.
helpful.
Thank you to Cytokinetics, and then our next Facebook Live will be in September. And we want to thank all of you so much, and thank you again, Kathy, for participating today.